Welcome back, everybody. Brad Staats again. Great to see y'all, and excited to get going with kind of our lunchtime speaker here, Gina Bartasi. Incredibly excited to have you with us, Gina, today. As folks know, she's a highly successful entrepreneur, decades of experience in health tech, and thinking about launching, growing, and exiting companies. Kind of recently, after she founded Progeny in 2015, company now that's a $5 billion public company. She then kind of continued to see opportunities within women's health, in particular, employers' desires to purchase fertility benefits directly, and using this feedback as well as kind of her rich industry experience. She launched Kindbody back in August of 2018. And so we have a chance to kind of learn from her about that journey and about Kindbody and broadly across health tech. Gina is speaking us today as part of the Dean Speaker Series. That's made possible through the generous support of the Archie K. Davis Endowment. And the series is one that brings outstanding leaders from business, education, and the government to share thoughts and insights with our community. Finally, I should make sure to add that we are incredibly fortunate to get to claim Gina as one of our own, as an alumna of the University of North Carolina. So Gina, thanks for being back with us today.
Yeah, thanks, Brad. Happy to be back. I love Chapel Hill. I grew up in North Carolina. I was back a couple of weeks ago for the Shuvert program in entrepreneurship, and I just love the campus. So delighted to be with you today.
Awesome. Well, thank you. And I'll remind folks that while Gina and I have kind of some questions we're going to go through, and we'll just make it a conversation that we'll head in different directions as we talk, that please share your questions, comments, either through the chat or through the Q&A feature, and we'll make sure to incorporate them as we go through things. So just to start off, would you mind kind of laying out the groundwork around your personal journey that led you to found Kindbody?
Yeah, sure. Kindbody is my fifth startup. It's my third startup in women's health. So I graduated from Chapel Hill, moved to Atlanta, and then moved to New York City in 2004. Met my husband when I was in my mid 30s in New York, out in the Hamptons. And we got married when I was 37, and that seemed young to be getting married. In fact, it's actually old. It might be young to be getting married, but it's old to be thinking about having children. Anybody over the age of 35. So now 1 in 5 women have their first child over the age of 35. But you are advanced maternal age if you have children over the age of 35. But we have trouble conceiving. We saw an infertility doctor on the Upper East Side of Manhattan. And that's what started this career in health tech and fertility. So the first company was Fertility Authority. That company was acquired in late 2014. The transaction closed in early 2015 by Kleiner Perkins and TPG, well-renowned venture capitalist on the West Coast. And when they bought Fertility Authority, they merged it with a medical device company called Oxygen. So those two combined companies created Progeny. That was a $5 billion market cap company, as you mentioned last week. They reported earnings yesterday, so it's now a $6 billion company. What I learned through that process is that you must be in the provision of care. You have to be in the doctor business in order to effectuate change in patient experience, patient outcome, and cost. And as a middleman, a call center, which is what Progeny is, we really couldn't help the patient. Most fertility clinics look like other legacy healthcare companies. There's a lot of paper. They still use fax machines to transfer medical records, and learn through, again, that process that in order to really effectuate change, you had to be in the doctor business. So today we have, soon to be 12 Kindbody clinics. We're opening in Charlotte, North Carolina, the first half of next year. So we have our own clinics, our own physicians. All of our physicians are women. Turns out if you're going to serve women's health, women patients prefer women doctors. And then we have partner clinics across the country. So now that we're in the provision of care, we can, in fact, create change in patient experience, patient outcome, and cost.
It's a great narrative and a kind of great path to get there. You talked a little bit about, kind of the need to get into the provision of care, but could you hit on what you saw as kind of the key barriers to success in this space?
Well, there are a lot of things. First of all, I didn't come from healthcare, and healthcare is incredibly, incredibly complicated, and it's slow changing. I think the future of healthcare really has to do with the commercial, who's paying for commercial insurance and who's paying for commercial coverage. We know that 50% of Americans today get their health insurance from the employers. So the big dramatic thing that's happened in healthcare is when the ACA was passed, employers that historically were fully insured moved to self-insured. They said, my premiums are going up double digits every month, or excuse me, every year. My costs are going up, but my members, which is what they call their employees, my members are less satisfied. So in fact, I want to take control of the spend. So they move from fully insured to self-insured. As a self-insured employer, it changes the relationship with the payers. They treat the payers almost as a TPA instead of paying them a commission, some sort of margin to sit in between them and the patient. And that really was the progeny model. We were being paid a margin to sit between the patient and the employer. So when we think about the changes and really what led to Kindbody, it really has to do with the healthcare landscape and how only the commercial side, when we think about family building benefits, there is not any Medicaid or Medicare coverage, so there's not a lot of government coverage. So we really think about the commercial payment system, how that's changed. And again, the movement of employers from fully insured to self-insured, that's really driven this model towards direct contracting. So today, we sell directly into employers. They eliminate that 24% commission that they would pay in a middleman, and we sell directly to employers. So we have 70 employers today.
That's great. And just as kind of background for those who maybe aren't as familiar with the fertility space, you mentioned kind of 35 and above is particularly a target area, but could you kind of share a little on what does it look like today? How has that perhaps changed recently?
Yeah, the big movement, as it would relate to this audience, particularly the student and the business community, is more and more women are being proactive about their fertility. It is really hard to be reactive and to get an infertile person that's too old to have children and make them fertile. It's actually impossible. What you have to do is educate. We believe knowledge is power. And so if we can educate younger women and men, certainly there is decline in sperm, just like there is decline in eggs, but there are more and more women who are proactively freezing their eggs. There's more and more mandated coverage, both for IVF and egg freezing. So we would tell you our target population is actually 25 to 45. And when we look at young women, they're being recruited. We know there's a war for talent. We know there's high demand for a new workforce. It is the number one benefit now that is requested when you have young graduates from B school, all the B schools, is the desire for their employers to cover egg freezing so that they really can have their family on their own path, that they can provide for optionality. Some, when I was 25 and had just finished college, I was living in Atlanta. I didn't want children. I didn't want to get married, and then, you're allowed to change your mind. So what we want to be able to do is provide men and women optionality and how to build their families. The other area that's growing rapidly in fertility is same-sex couples, LGBTQ plus couples historically. It takes a sperm and an egg to have a baby. And if you're same-sex men or same-sex women, it's impossible without assisted reproductive technology, which is fertility. You see a big push by all employers today to provide parity across healthcare, including racial parity, underrepresented communities, including LGBTQ+. So there's been a real movement, again, by the employer community to make sure that they can create parity across their populations, particularly as it relates to LGBTQ+.
Awesome. Thanks. So you mentioned kind of one of the key elements of the model is providing care yourself. And you mentioned also kind of healthcare is complicated. That's kind of a go-to line of mine, whenever talking about it. It's complex, right? And unfortunately, of course, we have to deal with that complexity. And so could you talk a little bit about, how you marry kind of some traditional business looks of things like creative marketing and new ideas, fast-changing strategies, as well as standard care delivery that's maybe not known for its rapid rates of change?
Yeah, thanks, Brad. It's not only complicated, but it's broken, right? And
Yep.
so I remember when I took over the medical device business at Progeny, there was some legacy technology, some hardware and some software that was not cloud-based. All of those, I think the payers are all well-intended. They want to serve this millennial patient today, but there are legacy systems And most of those systems don't talk to each other. It's legacy code. Again, I mentioned the paper that is robust. Facsimile machines, again, are the #1 ways today still to transfer medical records. So when we think about serving this millennial patient, we talk about the consumerism of healthcare. We talk about being digitally native. Today, overwhelmingly, when you go into your OBGYN or any subspecialty, it is still a paper form. You're still given a clipboard and a pen, sometimes a number 2 pencil to fill out. And that is, makes me nervous. Like your handwriting is hard to read. And now you're relying on a front desk person to enter your data. Not only is it complicated, but that system is broken because it's adding waste to the system. You've got to pay a front desk person to answer the phones, to take your information, to write down your credit card numbers from a copay. At Kindbody, when you have a lot of dry powder, we have raised 125 million in venture capital. We start with technology first. So if we're going to fix healthcare, we would tell you the way to fix healthcare is to contract directly with doctors. But before we hired a single doctor at Kindbody, we invest in technology. Of our 125 million in venture, the first 6 million went into a technology investment. So we own all of our own proprietary technology, our patient portal, our EMR, which allows for complete transparency to the payers, to the employers, and to the patients. So again, I think healthcare is complicated, it's broken. The complication comes out if you can replace humans. Now we save doctors. Anything that is difficult in nature is handled by a human, but anything transactional in nature, booking an appointment, paying a copay, all of that should be moved to technology. And by the way, the millennial patient prefers that. Like, again, I've yet to meet a 34-year-old female that likes talking on the telephone. They're like, what is this? And so you have to really think technology first.
And so that makes sense. And I could see building out the model, and you get the kind of patient consumer really excited about it. How do you work on the back end on the provider who hasn't necessarily operated in that manner in the past?
Yeah, I mentioned earlier, we have 66 physicians. They're all women. We do have a tendency, we'll hire younger doctors. Our chief medical officer is Dr. Lynn Westfall. She served for 23 years at Stanford Fertility before joining us full-time 3 years ago. And she really acts as a steward and a mentor to so many of these clinicians. But certainly, the recent graduates from the subspecialty program, which is the reproductive endocrinology, and it's called REI, Chapel Hill has a program. When those young women graduate from med school, they usually are in their early to mid 30s. And it turns out when you poll patients want physicians that look like them, right? They want black, brown, yellow, straight, trans, gay. Like that's what the United States looks like. And that's what they want their physician to look like. So when we recruit physicians, it's a similar manner that we recruit patients. They have access to the best-in-class technology, best-in-class marketing. They don't have to do lunch and learns. There's a robust marketing machine that really brings patients to them. The biggest difference that we're able to offer physicians when we're recruiting them is equity in Kindbody. So all of our team members, whether they're an ultrasonographer or phlebotomist or the front desk worker or our subspecialty physicians, everybody at Kindbody is an equity owner.
No, that's great. And kind of take the partnership model in a different way, right? You mentioned earlier, one of the things you had to learn was healthcare. And so I'm curious, have you seen, whether it's in the past or present, the challenges as you're working with your chief medical officer, as you're kind of dealing with that interface?
Yeah, I mentioned earlier the war for talent. The war for talent remains in healthcare as well. We have to hire engineers. I think, one of the things as we think about how we handle healthcare pre-COVID and after COVID, we used to insist that all of our engineers were worked out of our headquarters in Manhattan. So Manhattan talent is particularly difficult in terms of recruiting and retaining. Compensation is high. They're always recruited to the next greatest startup. What COVID did was say, okay, we can all work remotely. So the majority of our engineers today, we have 55 engineers. The majority of those work outside of the United States. So when we think about talent, whether that's on the provider side or the engineering side, we really have rethought, not just, and our engineers ex-US also receive equity in the business. But I think, again, we have to rethink healthcare. We have to it is easier to rethink healthcare when you're a startup and you have a bunch of dry powder versus being some of these legacy systems and trying to get, again, I think they're well intended. I think it's just complicated to get these tech stacks that are different to talk to each other.
Sure. No, I mean, I think that's, incremental change can be good, but also it can sometimes lock us into something like a fax machine that I think most of us would not point to as best in class anymore. You just mentioned COVID-19 and how it had shifted the workforce a little bit in terms of location. I'm curious to kind of poke there, more of how has it changed the business for Kindbody, both the actual delivery as you work with patients, as well as how you run the organization.
Yeah, I think, we have 11 clinics. Our clinical team members have to go to clinic every day. Our corporate team members, we have 355 people and probably 170 of those are corporate. The corporate team members have the luxury of working from home, and our clinical team members they have to go into the clinic. So as a founder CEO, one of the things we do, it's annual merit increase time, right? So our clinical team members now get 2x the opportunity for merit increases that our work from home people do, because there's no doubt that having the flexibility of working from home, I think everybody would enjoy. Our clinical team members don't get that same ability. And so we're going to reward them more, not only from an equity standpoint, but from a compensation standpoint, that our clinical team members will be rewarded 2x. And then, I mentioned it earlier, but when we think about COVID and how it's affected Kindbody, we are seeing more spread out, more remote. One of the previous panels talked about 80 of the 100 counties in North Carolina being rural and not having access to care. So one of the things we've done, and the answer was a mobile clinic, right? So we launched with a mobile clinic. Now, our mobile clinic launched downtown Manhattan, but we are taking that mobile clinic now to more fertility deserts where there's not access to care. At the heart of Kindbody, we really do believe in the consumerism of healthcare. So all of our Kindbody locations are retail. The brick and mortar locations today, our location in Charlotte is downtown on Tryon Street. They're retail. They look like a SoulCycle or a Dry Bar. This customer base of this millennial female expects a different aesthetic than a historical hospital setting.
No, that's great. And so you mentioned, a lot of the care y'all offer fundamentally has to take place with people together. Is virtual care kind of much of the model, and has that changed at all?
It is. Yeah, no, it is. And COVID, we were, again, tech first. So we did a lot of virtual care before COVID-19. Certainly, it was exacerbated during COVID. So we do as much virtual care as can be done remotely as possible, right? So we say virtual first, but not virtual only. Because if you are, when you go to healthcare partners and you speak at healthcare conferences, they say, well, do you prefer virtual care or in-clinic care? And I'm like, whoa, it's just care. Like we have to build a patient-centered healthcare system. And I would tell you, deliver the care how the patient wants it. Some patients prefer meeting with the clinician in person. Certainly an ultrasound scan, an egg retrieval and embryo transfer, all of those things have to be done in clinic, but we do think about virtual first. All of and Kindbody's offering is also more than just fertility. We know there's high depression and anxiety when going through fertility treatment. We know there's a lot of PCOS that can be remedied by exercise, nutrition, weight loss. So we offer a wellness at Kindbody. So all of that mental health support and that wellness support can be delivered virtually. And the payers are catching up. You're seeing that, it used to be that providers were not reimbursed, right? That we were not, as providers, reimbursed for a telehealth consult or a telehealth assessment at the same, even though the consultation was exactly the same. The difference was we're behind a screen instead of in person, but the payers are catching up, and we are seeing our reimbursements now be very similar in a telehealth solution to an in-person solution. So again, you're seeing this change to be more patient-centered, and the payers and the providers are certainly supportive of that.
That's great. Encourage folks, if you have questions, please use the Q&A functionality. To unpack that last bit a little bit more, I'm curious around kind of how you think about new product design in healthcare. And so, there's some amount, I'm sure you're just taking what was done elsewhere. And then to your point right there, mental health and how do you package that? And then of course, how do you sell it to someone? And maybe just starting with your, with the company side, how does that work?
Yeah. Again, I would tell you that the most successful entrepreneurs, or the success that I've achieved, is you listen to your customer and you listen to your patient population. So when we think about new products, we're launching an at-home product. So when I mentioned care, it's not virtual or in clinic. Those are two forms of care. I would argue there's a third leg to that stool, and it's at home, right? How much could you do an ultrasound scan at home? Can you do blood work at home? Can you do fertility assessments? I mean, the biggest challenge, and I mentioned this earlier, is it's really hard to get an infertile person fertile. We have to change the paradigm in reproductive health from being reactive to proactive. Well, 1 in 6 women in metropolitan areas will need fertility treatment, 1 in 8 across the United States. Most people presume they're healthy and that they can easily conceive. Imagine if we had an at-home test, both men and women. What people assume fertility is a women's issue because women's making the decisions, but 50% of all fertility issues are male related. It just happens that in a heterosexual relationship, the woman's still making the decision, even if it's a male factor. But we want to be able to serve more patients, more rural patients, and you can do that with an at-home assessment. So at the beginning of the year, we're going to do a soft launch November 15th, but we have these at-home testing kits. One is a semen sample and the other is a blood sample, so that we can, again, empower the patient. Knowledge is power. Folks that may believe they're fertile and they don't know it, but they have a diagnosis, either on the male side or the female side. If we can diagnose them earlier and get them in treatment earlier, their prognosis for success is going to be much, much higher. So an at-home test is coming.
No, I think that's super cool. And I mean, there are a couple directions I'd love to go. I mean, one is just, when you go to employers to talk about these things, how much are you having to sell them back to this point because their employees, at least in this way, better than they do? How much are they kind of well educated? And what does that conversation look like?
Yeah, it has changed pretty dramatically in the last 6 years. So 6 years ago, when I started Progeny, I said, fertility is going to be big. More and more people, the reason fertility is big now is because of all these macroeconomic trends. More and more people are waiting to get married, waiting to have children. You used to think it was a bi-coastal thing. You used to think it was New York and San Francisco and LA. That's not true. Like, my nieces live in Kannapolis, North Carolina, and they want to freeze their eggs. It's just, now it is across the United States that people are waiting to get, and by the way, across the globe, that people are waiting to get married and waiting to have children. So when I was raising money for Progeny, investors would say, oh, well, Google and Facebook, the tech companies can support a benefit like this, but not everybody's going to add a fertility benefit, or how do we know? Today, it's less of us selling into employers and more about employers are being asked. They're asking Kindbody. We have 2.4 billion in pipeline opportunity where those employers are coming to us. They want to purchase services direct, saving a 24% commission. And then the question is, okay, wait, wow, that's pretty cool. Instead of Kindbody having to sell into the employers are coming to us requesting services. What's changed in the employer side? And the biggest thing in the employer side is the demand from the member population. So again, 6-7 years ago, when egg freezing started to get very popular in the United States, I was on a Bloomberg interview and the reporter from Bloomberg was like, oh, well, these companies are paying for egg freezing so that they can chain women to their desk. And I was like, that's actually not the reason. That might be your perception because you're a male reporter and you haven't asked the female so what they want, but it's actually being driven by the member population. Same-sex couples are asking for a fertility benefit. I mentioned earlier, but these well-educated women that are graduating from school insisting on this benefit. So the members are insisting on the employers, and then it's changed the paradigm where, historically speaking, we had to sell into the employers. The employers are now actively looking to add a fertility and family building solution.
That's really cool. How much, so you've talked a lot about the employers. Do y'all spend much time with the payers independently? And how do those conversations look different or the same as the employer kind of based ones?
Yeah, the payers are doing a good job learning about the space, getting on board with adding a fertility benefit as well. 6 years ago, again, when I started Progeny, fewer than 10 states provided for a IVF or egg freezing mandate. I live in New York now. New York State just passed in January 2020 a mandate. If you're a fully insured employer in New York with more than 100 employees, you must now legally cover 3 cycles of IVF and egg freezing when it's medically indicated. So now 4.7 million new New Yorkers have coverage through their payer, through their plan sponsor that didn't have coverage. So it's a multi-billion-dollar opportunity for us as doctors. And the way that works is, listen, if you have coverage through United or Aetna, it's on a fee-for-service model, right? But you go to the doctor, but your payer, we get paid through the payer. So we love the payers. We have seen now Colorado, also there are now 19 states. So 6 years ago, less than 10 states that mandated coverage, 19 states. Colorado is just the 19th state. We know California, there's a similar law to cover fertility treatments on the governor's desk in California. So you are seeing not just more commercial coverage coming from employers, but more and more state mandates are coming as well. And that's where the payers come involved. You know, the biggest difference, and the payers know this, you know, as doctors, we'd love to get paid faster. There's a long lag of receivables by the payers. It's a low margin business. The payers are rethinking their own business strategy. That's why you see these Aetna CVS partnerships, because again, that legacy system where payers had a platform and they made a margin between the doctor and the patient, I think is changing dramatically as more and more commercial payers, employers want to purchase services direct. But right now, the majority of healthcare is still on that payer model. And so, you know, if they ask me what we'd like as doctors, you know, it's about a 90 to 120 day receivable. And the commercial payers just pay us a lot faster than the traditional health insurance companies.
Sure. No, that's I think in some ways back to the earlier discussion of kind of business and healthcare coming together, and things like accounts payables aren't necessarily where folks' minds immediately go. But I'm sure in a quickly growing company that you've got to think about these things. You know, that's the difference, right?
Yeah, or if you ask any doctor, they across the country in any, whether it's in primary care or in any subspecialty care, the 2 things that pain them are technology or the lack thereof. Even if they have an EMR, it's onerous. So there's a lot. So that's their biggest thing about burnout, wasted time. They spend a lot of time here. And the second thing is always getting paid. Like most doctor groups, unfortunately for them, fortunately for us, don't have 125 million from venture capitalists like Google Ventures to be able to rely on. There's a big cash crunch to these doctors who are often self-employed, right? And so it's not as a big a pain point. We'd still like to be paid faster, but what I worry about are like the local OBGYNs in North Carolina who provide a service and are not paid until 90 or 100 days later.
Right. Well, and then when mistakes are made, right? I mean, you can go.
Yeah, well, they deny the
find,
claim,
right?
and you have to spend another 100 days resubmitting the claim. Like if somebody measures what it costs to collect a $190 annual well woman visit, it actually costs more money to collect a $190 well woman reimbursement. Those are the things that are really taxing on the healthcare system.
Well, and to your point, I think that's back to being digitally native and getting to build from the ground up. You get to address a lot of that, at least for where you control kind of the interfaces, but then you have to plug into the legacy system on certain things too. Kind of a question here from Jonathan Zimmerman related to what we're talking about now. Asked, how does Kindbody work with other providers involved with patients' care, PCP, OB, GYN? How do you follow a patient as they move through the fertility process from referral to delivery?
Yeah, well, again, we're integrated. So with Epic, we're in integration right now with one of the other large EMRs. But Epic is the largest, and we started with them, and that's what has to happen. There has to be this seamless member experience. So in some of our locations, of our 11 locations, 8 of the 11, we have OBGYNs. We don't deliver babies. We do a lot of that other work, but when we do refer out or take a referral in, if that provider is on Epic, that sharing of data is seamless. And that's where we want to get with the payers as well. It's really arduous right now, but as we continue to work together, it will be seamless between provider to provider and from payer to provider. Anyway, that's how it's done now, is a referral process or a warm transfer. And in the best case scenario, that doctor is tech enabled and uses Epic. If they use Cerner or Athena, we are starting the process of integrating with them.
Okay. And kind of a follow-up then, I guess, to that is around, thinking about just as we shift to value-based care, and what does that mean in your context, where there's kind of integrated actions that need to take place, but also kind of this point of eventually we can think about broader goals.
Well, the industry has to move to value-based care, right? I'm a huge value-based care believer. In our Orlando location, we have a value-based case rate for the maternity journey, and all of our fertility services, except for the payers, are all value-based case rates. And that's really what the success of Progeny was about. If you had fertility treatment prior to Progeny, it was all done on a fee-for-service basis. And there's, again, a lot of waste in the system. So the goal was to say, we're not going to serve you on a fee-for-service, we're going to move to a value-based case rate. At Kindbody, we do that as well. I will tell you, the next iteration of healthcare is to go at risk, right? So it's not just value-based care, but now that we're in the provision of care, we are prepared to go at risk for our employers. So our employers, which are trying to control costs, the number one reason patients or employers don't go through with a sponsorship of fertility treatment or paying for fertility treatment is cost. Our cost at all of our locations are 30 to 40% less than our peers. And the question is, how can you have a premium member experience? How can you have high profile real estate, high profile doctors, high profile marketing campaigns, gorgeous design? It's because we have a lot less people because we use technology instead of people. But again, I think until we can get healthcare to really embrace not just value-based care, but to go at risk. And so our locations are already more affordable. And again, I think the next iteration, there's not a lot of that right now in fertility, but we'll be in a position to go at risk with our employers and offer money back guarantees to patients as well.
And I'm curious, I mean, how, pretend for a second that we don't have our existing kind of rules of the game and such, and you really went at risk. I mean, one of the issues I'm sure is just the time lag that's involved between kind of actions you take and whether they were successful. I mean, I'm sure you thought about this, like what kind of solutions would help to bridge that gap?
Well, believe it or not, fertility is wildly predictive. The doctor knows your chances of success. He knows how many cycles it's going to take you to succeed. He usually doesn't disclose that to you, because particularly if you're a poor prognosis case, but there is a tremendous amount of AI and machine learning. Like if I had your blood work and your semen sample from our at-home test, I, as a layperson, can tell you. So if you could better predict likelihood of success, then you can move to an at-risk model.
Interesting.
To your point, right now, we're waiting and others are proving out our model, and it does take time. We're looking for not just pregnancy rates, but live birth rates, right? We are big believers in single embryo transfer. I'm a mom of twins. There were too many twins 10 years ago and certainly 15 years ago. Today at Kindbody, we have a 96% single embryo transfer rate. We have no multiple births. Twins and triplets, no multiples. And still we have a 70% pregnancy rate. So that just shows you, again, if you're in the provision of care, you can move to value-based if you can get the payers on board. Again, we go to the payers now and say, you can continue to pay us on a fee-for-service basis. We get paid more, but we'd like to be innovative in healthcare. Of all the payers, we have a value-based case rate with one payer. The other payers have said, no, we have to pay you on CPT codes. And we're like, are you sure? And they really don't have the systems. They don't have the infrastructure in place to pay us on a value-based. So when we think about going at risk and waiting for the mom to carry the baby and get to that singleton healthy pregnancy, you're right, Brad. It is a long way between what we hope the future of healthcare looks like and where we are today.
Um, so a great question, kind of about a long way in the opposite direction. So it's from Ali Coco. She says, if we talk about wellness and conditions like PCOS, and when she thinks about reproductive or women's health, she thinks about kind of beyond fertility to menstrual or other reproductive conditions that can have a huge impact on women, even starting at a young age. And do you see opportunities for these types of patients kind of outside of fertility for Kindbody?
We do, and we address a lot of those now. So 1 in 10 women have endometriosis and 1 in 10 women have PCOS. PCOS has, it's associated with obesity, diabetes. These are underlying conditions. Again, that's when we think, notice that Kindbody is called Kindbody. It's not called UNC or United States Fertility Company. We don't think that there's too many things that affect your reproductive health that need to be treated. Again, diet and exercise, the mental health component. So we would never just focus on fertility. Now, as we think long-term about the growth and the prospects for Kindbody, we do think about going younger. Again, our patient population today is 25 to 45, but certainly we could treat patients earlier. And then we could, more and more employers are asking for a menopause solution as more and more of their audience gets older. So we do think about expanding, but there's so much opportunity with this core consumer of 25 to 45, again, and other women's health and treatment decisions, whether that's, again, lupus, endometriosis, just a bunch of issues that go undetected until someone is trying to conceive. And that's, again, in many cases, just too late. We have to be more proactive, and we have to diagnose. So arguably, we need to be able to diagnose these men and women from the comfort of their home.
Awesome, thank you. So you mentioned how there are legacy providers out there, and I'm curious how you either work with them or kind of coexist when you see each other at conferences or things like that. I mean, what are those interactions like?
Yeah, they're fun. I've been in the industry now a dozen years. And, when I went through treatment, everything was white coats, older white men, this legacy healthcare system where it's very hierarchical. And the patient, I always was subordinate to the doctor. And in a lot of cases, it's still the case where the patient feels subordinate to the doctor. At Kindbody, none of our physicians wear white coats. The tables are round. None of our physicians have offices. That is all intended for our physicians to feel like they're partners on the journey with these patients. Now, many doctors like their white coats. They like their big mahogany desk and their degrees behind them on the wall. And, and so listen, to each their own, we're seeing patients choose Kindbody. So, not all of those doctors are going to get on kind of the Kindbody plan of retail. They think, oh my gosh, like, why would you ever have a location in Austin, Texas? Our location is right downtown at the corner of West Cesar Chavez, right downtown. Like, again, I mentioned our Charlotte location, in Austin and in Denver. In New York, we're at 102 Fifth Avenue, right in Union Square, really close to NYU. Nice. That is not for everyone. Doctors like going to the hospital. And we've said, even before COVID, we said, our patients are not sick. Why would, sick people should go to the hospital? And we would say that before COVID. Our patients are trying to have a family. They're not sick. So why would you send them to a hospital setting? But some doctors, again, feel better about their white coats and going into a hospital setting. So, I've known them a long time. It's congenial now. We like them. And they do say now, they're like, well, we're hiring more women doctors. I'm like, great. Do you give them equity? Because we really want to create parity in healthcare. And it's not just hiring women doctors. I checked the box. We hired women doctors. We do want to change the landscape in the boardroom and wealth creation in this country. And we think we do that by giving women an ownership position at Kindbody and in these other provider groups as well.
No, I mean,
don't say yes. When I ask them if they grant them equity, yes, you've hired female doctors. Okay, great. Do they own part of your practice? They go in another direction.
Yeah, exactly. I need to get coffee or something.
Yeah, exactly.
But, I think, there's a couple of important points there, I hear at least. One is just in the, as we think about change in healthcare, there are a bunch of these things that come out and we say, well, everyone of whatever category, be it doctors, be it somebody else, they're not going to want that. And, maybe not, but does a subset want it? And can we start with change there, right? And so I'm sure 100% of med school graduates aren't going to want to rush to join Kindbody, but if enough great ones do at various stages of their career, then you go from 8 to 11 to, lots more clinics. And I think that's one of those changes we're seeing. And to your point, then second, I find it fascinating that, the omni-channel retail comparisons that we get to healthcare and kind of what omni-channel healthcare means, and the world we're going to see in these next few years of whether it's kind of a digitally native organization like yourself coming up, some of the retailers kind of moving into the space, but there's some really important overlaps that it feels like there's lessons to learn in whatever direction, or even legacy healthcare, thinking about how they can shift things.
That's right. And I think, where it was evidenced first, we study lots of other retail healthcare businesses. Where it was popular first was in primary care and urgent care, right? And then, so we looked at those models, and in many cases, you see them JVing with large health systems, right? And so I was like, okay, well, I get it for the health system. This, again, somebody asked about the provider to provider referral. That historically was the case. If you were a subspecialist, if you were an REI, you relied on the OBGYN to refer business to you, and then you sent it back to the OBGYN. Today, 60% of millennial women do not have an OBGYN. They get their well woman visit, if at all, but they get their well woman visit from the doctor in the box down the street, one medical, an urgent care or primary care facility. This OBGYN, the referral model has broken down. Today, less than 1% of our business that's growing rapidly comes from an OBGYN referral. The majority of our business and other fast-growing businesses come from Instagram. So now you have to think, wait, wow, healthcare is really changing. The patient is not coming from a referral from a primary care doctor. The patient is coming from Instagram, but that's what's happening in healthcare. And as patients make choice, see what's happening is consumers, the patients are empowered with choice today. And again, it's because, the payers have been pushed to open up broader networks and to allow for more doctors in the network. Otherwise, patients make the decisions to go out of network and just pay out of pocket. And so while these changes are happening, you're seeing patients make choice. And when they make choice, they feel empowered, and they're susceptible, and they like this omni-channel marketing. Like, there's a lot of private equity now coming into fertility, and they're buying up these fertility practices, but they're not creating a brand. Like, we believe in the brand power in this millennial patient as well. They want to know, and they're very transient, right? I just moved from Charlotte to Austin, or Austin to Houston, or Houston to Dallas. They take comfort that Kindbody, a trusted source, a trusted brand to them, is now nationwide. So again, it's this entire rethinking of healthcare that is patient-centered, and this millennial patient who doesn't have a primary care doctor today.
Well, and then that ties to your earlier discussion around kind of the at-home testing that you're providing, if that's not going through the PCP or OBGYN, in addition to your medical indication point for, getting things funded by the payers in new ways. You're driving the bus as a result of all of this to really support people with what they need.
That's right.
So I could keep digging into the care side, and maybe we'll come back to it, but I want to take a detour for a second around kind of your experience in building the company. And one of my questions is around, you mentioned the 150 million that you'd raised, but if we look kind of at the stats, back in 2020, it was around 2% of venture funding went to women-led companies. 2021, I think, has bounced back a little bit better. But this is despite the fact that there's studies showing kind of really significant returns per dollar invested, for female versus male-led companies. And so, could you talk a little bit about your own experience successfully raising money as a woman, and what we should know?
It's hard. It's really hard. It's disproportionately hard for women. It's way disproportionately harder for women that are BIPOC. It just is. It's because if you're an investor, you are writing a check to something or something you can feel empathetic for, or that you've seen or gone through before. 2.7% of all venture capital goes to women. It's going to men because men are writing the checks. The majority of general partners, so you see more venture firms and more private equity firms hiring women, but they're associates or principals. So it's window dressing, but they're not general partners. They can't scrutinize a deal, they can't lead a deal process, and they can't write a check. Until that changes, until we can, again, it goes back to wealth creation. The folks that make GPs and investment firms have made money for other people, and they have wealth creation. They often have to write their own check into the fund, and they can't do that until we can give more women the opportunity to be owners. Then they can create wealth, then they can be general partners, and then they can write checks to found other entrepreneurs. It has been significantly easier for us to raise and me to raise at Kindbody. We raised money very quickly. We raised money early on very quickly. I went back to my exact same friends and family that had done very well in Progeny. Many of them made kind of 25x plus returns. I said, we're going to build a better mousetrap. It was really easy to raise. We just closed $62 million at a $612 million valuation in late spring, and we're going to go raise our Series D, 100 million plus at a $1 billion to unicorn status. Again, it's easy for us to raise now because Progeny's done very well. And again, I haven't seen the stock today, but yesterday they reported strong new customers. We have strong new customers, and I think even men now today understand the opportunity in women's health and fertility and family building. So many of the investors are looking for the next Progeny, and can I buy in $1 billion company that could be worth 5, 6, 10, 15. And the biggest difference between Kindbody and Progeny or any of those other middlemen is simply the margin profile. Again, I think the margins for the insurance companies are going to, if they're big now, they're going to be squeezed long term. When you're in the provision of care, you can enjoy much better gross margins and net margins, particularly on a direct to consumer side business or on the employer side or even on the managed care side. But anyway, so we're having a lot of fun. It is easier to raise, but it was hard. I mean, remember, this is my 5th startup. The first 4 were always undercapitalized. We raised money, but we never raised enough. It was hard to raise. So there are some advantages of being old, Brad. It makes it easier to raise money.
Yeah, no, I tell myself that on a regular basis, Gina. I don't know if I always believe it, but it makes me feel better. I guess kind of related, as someone who has been doing this for a long time successfully, are there other aspects of being a female entrepreneur that you'd highlight, either as challenges or, as you think about them as advantages, and kind of bigger picture, how have you managed that?
At Kindbody, we are not completely women. We are majority women on our executive leadership team. There are 10 of us. We have 2 dudes and 8 women. I like working with women. Women multitask well. I find them very decisive. I think they're equal parts decisive and empathetic. We say at Kindbody, kind does not mean weak. Please do not mistake kind for being weak. Kind and strong, and you have to balance that. And I think women do that very well. And so I think it's been an advantage. It has not always been an advantage because you were at a tremendous disadvantage. Oh, you're a female entrepreneur or a female CEO. You do now see both gay men and straight men want to now work for a female leader. We lead differently. Again, we're more compassionate. We have a tendency to be more thoughtful, but quick to make decisions. So, we were just hiring, we just hired 3 dudes in the last 3 weeks, and they all said, I said, why would you work here? And why would you come here? And they said, I've always worked for men. I'd like to work for a woman. So now you see them, these are men who are proactively choosing to work. Not just our president is female, our CFO is female, our chief business and legal officer is female. And so now it's been fun and rewarding, since I've been at this a while, to see not just women want to work with other women, but men want to work with other women leaders.
That's awesome. I think it's on the business education side, opportunities for us to write some new cases and think about kind of showing a lot of the different stories that we need to better highlight, I think is the right word. Kind of if we focus on the business side, I am curious, you have experience scaling. And so we often focus a lot on startups here. As you can see, our entrepreneurship center spends a lot of time talking about scale. And so could you kind of reflect on your lessons as you've shifted from startup to scaling, kind of what challenges arise, how have you overcome those?
Yeah, I think, again, as an entrepreneur and as a CEO, you have to understand your strengths and your weaknesses, and then you have to decide how you want to lead. So again, there are different leadership styles. My leadership style is we play to strengths. We don't focus on weaknesses and say, okay, how can we make your weaknesses strengths? We play to everybody's strengths. My strengths are vision, big picture, scale. I'm not a detail person. There's like, I have a million weaknesses, but my president is Beth Eschbach. She does everything so well that I don't do, and I do things well that she doesn't do. And so again, our team is really strong because we believe, again, in strengths-based leadership. And so that's how we think about growth. It's how we think about scale. We are vulnerable. We say every day, it's an asset to ask for help. Asking for help is a sign of strength, not weakness. And so when you're going through scale, I think you have to remember to stay flexible. You always should stay humble, whether you're growing at 10% or 30%. I also think, as a native North Carolinian, when my venture investors asked me 5 years ago, well, aren't you going to take Progeny public? I was like, what? I was like, no, I'm not taking this company public. I'm like from Hickory, North Carolina. Neither one of my parents graduated from college. Like, I'm not even sure what I'm doing here, and now, because you've seen so many other women-backed businesses, I think about Bumble, I think about Figs, I think about Rent the Runway. There are these kick-ass, I'm sorry, I'm not specific. There's these rock star women. And now we're unapologetic that the scale looks like us for an IPO. And the IPO is near term. It's for sure multiple billion-dollar opportunities. And that's how we really create change, again, in this country, is more people need to see other women raising at a valuation that is reasonable and take companies public and do well by their patient population, their providers, and their shareholders. So scale is not easy, but surround yourself with a great team and then learn along the way. Again, 5 years ago, I was like, wow, take a company public. That seems like a lot of work. Now, today, everybody is aligned. Now, the way we have to do that is we have a 92 net promoter score, and that speaks to our clinical team being maniacal about extraordinary patient care. So we can't put, an IPO in front of first and foremost. We have 70% pregnancy rates. We have a 96 single embryo transfer rate. We have no multiples, so extraordinary clinical care, extraordinary clinical service. Our net promoter score in 18 months of opening our own clinics has never been below 89. And if that net promoter score would start to wane, then it extends the opportunity for us to get the company to a public company. So again, extraordinary clinical care comes before the business goals.
And I like that, kind but kick-ass as you think about things. You were talking about learning, and I love kind of the lessons around playing to strengths and not focusing on the weaknesses, kind of complementing yourself with the broader team. One topic we talk a lot about is failure. And so I'm curious if you could share kind of an example of where you failed in your career and how you learned from that experience.
Yeah, I've failed a million times. And we say that at Kindbody all the time. We say embrace failure. And our doctors are like, what? We just graduated from medical school. Like, you can't fail. And I'm like, no, you're supposed to fail. Again, I fail a lot. Like right now, the business is growing fast, and I've seen fast growing businesses before. And, we've hired a bunch of people and we don't have OKRs and KPIs for everybody. That's a failure as a leader. I'm supposed to be able to hold all of these people accountable, and we're hiring so fast. Like, I think many of them have been hired during COVID. I haven't met them. They have not met me. That's true for probably 75% of our workforce right now. That's a failure. Business travel is picking up again. So I'm getting into the field more to meet. We're opening Minneapolis. So I'll be in Minneapolis a week from Tuesday. I just think you have to stay humble and stay grateful. And I'm grateful for this opportunity again, to come from a small town in North Carolina to go to an extraordinary liberal arts university. And to, again, I think we'll take the company public in the next 12 to 24 months. That is a blessing. The number one thing that has created that blessing and that success is hard work. So you have to hard work, you have to stay humble and gracious the whole time, and surround yourself with people better than you and smarter than you.
Yep, no, that's awesome. Kind of a couple questions as we get near the end here. One, what excites you about the future of healthcare?
There is more capital coming into the marketplace. I believe other doctors, I believe other payers, I believe other healthcare partners want to do the right thing. A lot of times they're capital constrained. So for decades, the capital in the venture capital and the private equity capital was all going towards technology. And about 2 or 3 years ago, it's only been recently, all the capital folks have said, okay, what is the next $1 trillion opportunity that needs disruption? And it is healthcare. So if you are relatively new to healthcare, I used to be in media and advertising. I didn't know anything about healthcare until 6 years ago, but it is fun to be in healthcare right now. Every other word in healthcare right now is innovation, and it takes capital to fund innovation, whether that's on the biotech side, the life sciences side, the research and development, like all of that takes money. And historically, all that money was going to technology. Today, there's quite a bit of capital flowing into the healthcare. So that's really exciting as we think about the future. More and more people are prepared to take risk and big bets in healthcare. And that's how you create change. And change does not come quickly without some capital behind it.
No, I think it's a great point. And, I tell everybody around here, there's never been a better time to be looking at the kind of these different aspects and business aspects of healthcare, frankly.
Well, and you look at the technology company, right? Like all the big tech companies, where are they putting their resources right now? In healthcare. Amazon started primary care. They've started virtual care, Google, Facebook, Walmart. I mean, they're all of these big tech companies that have billions of dollars of invest are now investing in healthcare.
No, I think the kind of the tech and retail overlap with healthcare and what it's going to mean both with new things as well as partnerships with existing providers. There will be some disruption, but I think a lot of just kind of reorganizing what we see. Rapid question, and then my last question. The rapid one comes from the audience. Ashutosh asked, are you thinking about looking at solutions in other areas, other chronic diseases, diabetes, things like that?
Maybe, but not right now. We're focused on women's health, and women's health is not just fertility, but it is maternity care.
Okay, awesome. Then kind of last question. We've got a large group here of folks who hope to be future leaders in healthcare. And so what advice would you give to the men and women in the audience today who want to lead healthcare organizations, want to be a catalyst for positive change in their communities?
I've mentioned it, but it is hard to underestimate the value of hard work. It is hard to underestimate embracing failure. When you fail, it creates more opportunity for success. You have to be hungry. I just gave a speech to some of our clinic directors, and one of our colleagues, a teammate from Atlanta, she was like, are you sure? There's this perception if you've had this success, you must have grown up in a wealthy community. You must have rich parents and a silver spoon in your mouth, and that's how you got. And I was like, no, my parents never even went to college. I'm not a prep school kid. I went to a state school, arguably, in my opinion, the best state school. But, so I would encourage everybody to start their own business, to take risk, to learn from that failure, and to know the sky's the limit, particularly if you will stay humble, stay kind, ask for help. And when people give you help, tell them thank you all the time.
Well, Gina, we are extraordinarily lucky both to get your time today and to have you as an alumna. Thank you so much for spending it with us. I know if you were here, there'd be kind of roaring applause. So we can't quite, kind of that to bear. but we really appreciate you joining us today.
Yeah, it's my pleasure. You can tell my passion both for the disruption of healthcare and for the university. So thank you for your time today, Brad, and UNC. Yeah. Take
Absolutely. Care. Go Heels. Thanks. Bye. So everybody, we'll take a 10-minute break. And at 1:25, we'll be back for the finalist team presentations and winner announcement for the UNC interdisciplinary case competition. So until then, on a break.